Hi there, my name is Kristen Posey-Wallace. I'm the uterine transplant nurse. I have been in labor and delivery for over 10 years, and now I'm a part of the transplant team. I'll be with the patient from the first phone call all the way through the transplant, the pregnancy, delivery, and then the follow-up.
I'm Giuliano Testa. I'm a transplant surgeon at Baylor University Medical Center, Simmons Transplant Institute, and I will be the principal investigator, in reality, teamwork with all my colleagues here at Baylor.
I'm Göran Klintman. I'm the chief and chairman of the Transplant Institute. I was the one that actually established organ transplantation here at Baylor 31 years ago. And I will be part of the team. Colin?
I'm Colin Kuhn. I'm a GYN oncologist here. I co-chair the robotic steering committee here at Baylor University Medical Center. There are a couple of other people that are kind of key members of the team that are unfortunately not able to be here. One of those is Dr. Alan Stringer. Dr. Stringer is the chair of the Department of Obstetrics and Gynecology here at Baylor, and he's also a GYN oncologist. The other person who's unfortunately not here is Dr. Robert Gunby. Dr. Gunby is an obstetrician and gynecologist, and his main role in this project will be to oversee the obstetrical aspect from after the embryo's been implanted to all the way up to C-section delivery, so from the OB-GYN standpoint. My role in this is to kind of oversee a lot of the OB-GYN aspect of this. This will include also the harvesting of organs, the helping to implant those organs into the recipients, and then to kind of oversee the process, watch for rejection, and then also at the end take out the implanted uterus once we're finished with it.
I'm Michael Putman. I'm a reproductive endocrinologist, medical director for the Fertility Center of Dallas. So my role is going to be doing the in vitro fertilization, being able to do that on the subjects initially, then freezing the embryos, and then in future date being able to thaw the embryos and do the embryo transplant after the patient has successfully had the uterus implanted.
Baylor University Medical Center has one of the largest multi-organ transplant programs in the United States of America and in the world, actually. We have a long history from the very beginning of developing new procedures, new ways of doing known procedures, and not just procedures, but also how to treat the patients, new drugs, new immunosuppressions to prevent rejection. And this is a trial that is about finding out how to do uterus transplants. There's no rules or game books now. There's been 5 successful pregnancies in the world to date. So we are in the very beginning of this. And everything we do here will be based on the recommendations and findings from Gothenburg, Sweden, where they have done those 5 cases. And we then will add to that, and we will be working in very close collaboration with the other centers in the United States. Right now, there's 2 other centers who are moved very fast and very much forward together with us, and we have a very close collaboration with them. So we have to understand, and I want to make this clear from the beginning, this is a pilot trial. We have picked the very best physicians and nurses, not just the ones you see here, but virtually the entire time the patient is in this program, or patients are in this program. They will be surrounded by a cocoon of the most skilled nurses, the most skilled physicians that this institution has to offer, from the time of implantation to the finishing of the delivery, the cesarean section. So this is something we have done for years, for many years, and we will now apply what we have learned all these years to uterus transplantation. And I will ask Dr. Testa to give you more insight in what this protocol actually is. Giuliano?
Thank you. So, as you may imagine, we're very excited about this new adventure, if we may call you that, for uterus transplant. I think that at the end it will benefit many, many women who today have no access to carry their own pregnancies. Why here? Simply because there is a syntony of expertise with all the departments in this very prestigious institution, and we have a lot of support for doing this innovative surgery here. We have established our name in the transplant ward and in the living donor transplant ward. So we have active programs for kidney and livers, heart, lungs, pancreas. And the uterus come to fall perfectly in a very strong environment. And we hopefully be successful in performing this innovative surgery and giving thousands of women the possibility of carrying their own pregnancy. That's our goal, based on a strong ethical and also structural institution, that's Baylor. And I guess if...
Open up to questions now.
Yeah.
Can you describe the process from start to finish? I know we have that information for us, but some of us need it.
We are going to, of course, screen the candidates. The women are women who unfortunately have no uterus and cannot carry their own pregnancy. If they will fall within the criteria that, as Dr. Klintman just mentioned, are mimicking the one that are being successfully applied in Gothenburg, Sweden, we will allow them to go through an evaluation process, which steps will be described if you need to know those. And if everything goes okay and we have embryos already on the side for them, then we'll do the transplant. About a year after the transplant, we will transfer the embryos and we will hopefully have a successful pregnancy. The pregnancy will be carried on to possibly a term or close to term, and then the woman will deliver by cesarean section. And after that, they will be given the opportunity either to have the uterus removed. And the reason for that is that, of course, during the time of the pregnancy, the woman will have to have immunosuppression, and we don't want to prolong this unnecessarily. Or if they are willing to undergo another pregnancy, they will give them that opportunity as well. And then afterwards, that's for our protocol at the present time with the present knowledge is as far as we are willing to offer is 2 pregnancies.
Can you explain why?
There is no really a specific reason for it. Of course, more C-sections on a uterus is transplanted, of which most of the things are known, but some are totally unknown, is probably not safe for the woman. On the other side, this is not a life-saving procedure. If you would, this is a life-giving procedure, but we do submit the patients, so the woman to immunosuppression. We don't want to prolong that too long.
What other criteria, aside from the obviously not having a uterus, would a woman have to, would need to qualify for this?
Colin, you want to address this?
Age range, anything else like that?
Essentially, we want to maximize an opportunity to have children. You have to remember that what is the main goal that we're trying to treat here? We're trying to treat a condition called absolute uterine infertility. And so we want to make sure that that infertility is specifically because either the uterus is absent or it doesn't work. And it doesn't work because of anatomic problems that it has. There's lots of reasons for infertility, and Dr. Putman can elaborate more on those. But we want people to be of normal childbearing age. Maximum age would be 35. Right now, we are, when you start a new surgical procedure, you want to kind of optimize your patient. We don't want them to be too big. We don't want them to be too thin. We don't want them to have a lot of medical comorbidities that may be complicating the pregnancies even more so. Once we get a system down and we're able to build on it, then we can start bringing in more potential complications and stuff. But in the beginning, we really want to set our foundation with very healthy patients and who would expect to be carrying babies if they had uteruses or normal fertility.
This trial was tried in Cleveland last year as well, right?
It has not been tried yet. They have just listed their first patient. So, I mean, Cleveland Clinic, Nebraska, who is have a little bit more paperwork to do, and ourselves are the three that are essentially have protocols in place and we can expect to get active during the next few months. And everything we do is based on the experiments done at the University of Gothenburg for the last 15 years. And again, as you have heard, this is experimental surgery. This is what we did in kidney transplantation 60 years ago and in liver transplantation 50 years ago and 40 years ago. We have to figure out how to do it safely before we can start expanding on that.
Do you have patients at this point that are getting ready to go through the process?
Christine?
We're ready to start screening now, so we don't have any active patients yet.
How many will you try on first?
Our trial is for 10 patients to do 10 transplants. So if that takes 150 screenings patients to get 10 actual subjects enrolled in the study, we'll screen as many that we have to get the right patients in our study.
It's just, you said that it's still an experimental procedure. What are some of the risk factors for women? I know they've done it in Sweden. They've had several successful pregnancies.
Well, there are many risk factors, and I think we can all pitch in about that. I mean, we're talking about something that Juliana mentioned several times. To be on immunosuppression is not something you want to be on if you don't have to. And this is not life-saving, so we try to minimize the time the woman will be on immunosuppression. That's one. And then, of course, with any surgery, there is risks. And then we sort of have all the issues. This is new and unknown for all practical purposes. We had a meeting we traveled to Gothenburg, all the three of us plus Dr. Gunby, the first week of January. And there was a meeting of all in the world who have an interest in this. And there were like 30, 40 people there, right, Giuliano? And they went through everything they knew how, and we have had them here as well last October. So this is about exchange of information. Try to understand what it takes to make that patient transplantable, who should be transplanted, how you do it safely, and how you get the pregnancy done through the pregnancy safely for the mother and for the child. And the success here, and I have to emphasize this, success here is not the transplant. The success here is the birth of a healthy baby.
Speaking of that, you were saying it's not life-saving, it's life-enhancing. I mean, you speak with the women from the first phone call to, you were saying till the end. Can you describe what some of these women or past patients say when this option is available to them?
Christine, I think you and Gambi would probably be the best to answer that.
I think this is offering an opportunity to these women who didn't really thought they ever had this opportunity. The only option for these women before were adoption and surrogacy. So here we're offering, a lot of these women that are just hearing about this study didn't ever think this was a possibility. A lot of people may not want to do this because they have come to accept the fact that they won't have children and have already pursued other means. But for those women that the only thing they ever wanted to do was carry a baby, this is giving them the opportunity to do so.
Christine, can you talk to what the ideal candidate would be? Age range?
Well, we want them between 20 and 35 because that's healthy pregnancy age. We want them to be physically fit and healthy with no major health concerns. They need to have working ovaries, which will help us have healthy embryos. And no, like we said before, no major medical surgery history that would keep them from carrying a baby to term.
Where does the transplanted uterus come from? Who is the donor, or how does that all work?
Do you want me to?
Giuliano?
Yeah, there are, in our IRB protocol, we specified that we're having the possibility, we're giving the woman the possibility of having a living donor and a deceased donor transplantation. And the reason for this was, of course, the only success to date has been given by living donation uterus transplant. And so, of course, we have to go with that. And we, as I said before, have a very good infrastructure and history for living donation for other organs. And from a technical point of view, I know we are very well adapted to deal with the difficulties of transplant of this kind. On the other hand, it may be that some of the women won't have a donor available. And then, of course, here comes the possibility of doing also a uterus transplant with a deceased donor. So we're opening to both opportunities, and this, I think, enhances the chances of many women to have this transplant performed.
Do you think it'd be difficult to come across donors?
Uh,
Are you willing to?
Maybe
What percentage of the population
Colin,
would this be useful?
Colin, why don't you speak to the donor population a little bit?
Well, it's one of the things, and again, our lessons are learned by what's happened in Sweden and in Gothenburg. That was one of my questions too when I first was addressed with this issue is kind of what would the donor pool be? And the response, at least in Sweden, is that the donor pool has literally come out of the woodwork. That people usually, we ideally would like to have a living relative. There may be some fascinating immunologic advantages if it's actually the patient's own mother, and that's the first one that was done, was like that. So but as far as that, there have been other additional relatives or even in-laws, I think was also one of the early ones too that was done, was an in-law. So, but really, they said that the donors have really stepped forward from that standpoint. So it may not, but you don't want to assume that everybody has that opportunity, and so addressing it from both a living donor and also a deceased donor are good options and would increase the pool for the patients.
What's the ischemic time for a uterus?
We don't know.
It seemed to be fairly resilient to injury with time, but honestly said that the only studies we have are now human studies. And so that's one of the things that Dr. Klingman properly said in the beginning. We are going sometimes into uncharted waters. In the beginning, it will be very safe. I can tell you we will keep that as we do for heart transplantation, where it's within 4 hours of the explant. And I think that's a very safe approach.
Once the transplant is successful, then, I mean, does the woman get pregnant naturally, or do you have to have another procedure? How does that work?
No, we would have already, in their criteria selection, we would have already had them undergo in vitro fertilization. We would have retrieved the eggs. We would have fertilized them. And then we would have also done a special procedure called a blastocyst biopsy to look and make sure that that patient has the highest quality embryos judged by the embryologist and a normal number of chromosomes to give them the best chance for pregnancy. So in vitro fertilization with a single embryo would be the way that we would go, because you really don't know how long it would take for someone to try to get pregnant naturally, and it may extend past the time. So we want them to get pregnant as soon as they can and with the best opportunity, and that's why we choose that single embryo.
For people going through IVF
Yes.
For years, which seems to be the case in the mid-30s in the UK at least, is this an option for them, or is it a separate problem? Or is that a market that eventually would be organised?
You mean as far as going through IVF and then
having a transplant, would it help? If they're not managing that?
not if you already have a uterus, but and we have gestational carriers that have been used in the past. But for patients with, am I understanding your question correctly? Yes. So no, that would be no value for that. What's value is for someone who is either born without a uterus or unfortunately lost it. I went to about 20 years ago, I was invited to Sherman to the local television station for an infertility talk, and they had a call-in session and had a young woman call in and said, you know, I lost my uterus, it's an emergency, can you transplant a uterus, you know? And sadly, I had to say, no, the technology doesn't exist, but today it exists.
Are you requiring the recipients to be from the Dallas area?
Well, I think originally there's nothing in our inclusion-exclusion data that says that they can't be from far away, but the reality of it is they are going to be seen so often. There's a lot of visits with us to make sure that they are staying healthy and that their pregnancy is healthy. They're really going to have to relocate and be local. Maybe not forever, but for during the transplant and the pregnancy, it's going to be important that they're close by, within a reasonable distance to the Metroplex, because we're going to need access to them, and they're going to need to. They're going to have a lot of visits with us, so they're not going to want to. And if they were to need emergency care, we would want them to do that here, where we know the protocol and where we know what medications they're on and understand their condition, and not go to an outlying facility that's not familiar with the transplant.
Yeah.
You consider people from outside the area if they're willing to relocate?
Let's just make it very clear. They have to be living here. Okay. We will see them. This is not just a procedure and then an implant and then a pregnancy. We will monitor these patients on a very tight schedule to make sure that we don't have a rejection of the uterus. And if there's a rejection, meaning the body is trying to get rid of this foreign organ, we will have to treat them. And this has happened to actually most of the women in Sweden where they actually did the transplant. So we must have access continuously, if necessary, for these women to be able to come to be seen by us. We have to be able to sample the cervix to look for rejection, because there's no lab value. You can actually just do a blood test and see if there's a rejection. This is only by pathology. So there are logistical requirements that must be fulfilled.
But I understand that, but if somebody was from Colorado and said, I'm willing to go to Dallas and live there throughout this, you would consider?
Oh, yeah.
Absolutely.
Absolutely.
Are there enough cases here in Texas or in the Dallas area that you guys would have to select from? I mean, just
Colin maybe, or Dr. Footman can give you an idea of the numbers we are talking about.
Yeah.
What's that?
Colin, how many, the question is, how frequent is it for women to be uterus infertile? I mean, and how many patients may there be, or women may there be in the Metroplex alone?
So, go ahead.
But when you look at not just the congenital abnormalities, and these are patients that unfortunately are born without their uterus, but also women that at a young age have had, just like we were talking about, have lost their uterus from different issues, but still retain their ovaries, and have lost that opportunity to become pregnant. So that's a pretty substantial number when you look at the whole Metroplex.
Yeah, and it's not, there's other patients as well. So, I mean, obviously, if you've had benign indications for hysterectomy, certainly, but then, as something that I'm very guilty of myself, I'm a cancer surgeon. I take out uteruses with cancer. And from that standpoint, it's a tremendous opportunity to restore fertility in somebody that's lost their uterus from either a benign reason or a cancer reason. If it's cancer, they need to be 5 years out from their diagnosis. To clarify one question that you had asked as well before, the uteruses, if we feel, again, we're treating absolute uterine infertility. If your uterus is gone, well, that's pretty much uterine infertility. If it's grossly abnormal, if there's anatomical problems, and if we feel that that's the reason for the infertility, even if they have their uterus, but maybe it didn't form right, something called uterine didelphys is an example of that, then that would be someone we would consider on a case-by-case basis to consider. But we'd want to know that was the only problem and not another problem.
So to answer your question, there were 9 women who stepped forward to have a uterus transplant in Sweden in a very short time. And Sweden has a population of about 8 million people. So translate that only to the DFW area, you see that there probably is not going to be a shortage of interest, at least, for many women to have this procedure.
I got one more. Can you speak to sort of the ethical concerns of putting a woman through this highly invasive surgery when it's not life-saving?
Yeah, absolutely. This has been discussed at length. As a preface, I have to say that the first step that we took in this institution when we came about the possibility of doing uterus transplant was to consult and present the possibility to our ethics commission. And there was, of course, no opposition, otherwise we wouldn't be here, honestly. The risks are clear. We know what the risk of immunosuppressions are. We know what the risks of the surgery are. So as long as the risks are known and the person can make an autonomous decision regarding undergoing the procedure, we are respecting the ethical principle that drive medicine today, which is autonomy and respect for human being. And I think this is really the basis of the program here that applies to any single procedure is done at Baylor. Is everything will be done according to the ethical principle that are driving medicine today.
Yeah. And we have had these, this review, ethics review, as you just heard from Dr. Testa. The first thing he did was to actually go to the ethics committee. Then we went to the intestinal review board and had a second ethics review. And then we had a third ethics review outside these two committees, but essentially in leadership, within leadership. So, and I have also to state that actually Dr. Testa has a master's in medical ethics. So this is something that is very close to him. He has a passionate interest in ethics. So we have taken, well, bent over backwards to make sure that this is the right thing to do.
All right, thank you everyone.
Thank you.